Hello and welcome to the Journeys with PDA Coffee Chat podcast, where we seek community connection and co-regulation while chatting about all things PDA. Hello and welcome to Journeys with PDA Coffee Chat podcast. I'm Heather.
And I'm Kerissa, and today we are here on part 3 with Sarah. We kind of feel like old friends now, and which I love. That's kind of what Heather and I like to do. We meet new people, then you become our friend.
One of us.
Yeah, we just bring you in kind of to our community and into our circle. So we have had some really fascinating discussions with you. I learned so much, and we've gotten a ton of positive feedback from the first 2 episodes. So if you're listening today, it's okay to start here. If you have not listened to part 1 and part 2, so you're fine to keep going. However, make sure that you backtrack and listen to part 1 and part 2 with Sarah Martin. Just fascinating information, so incredibly supportive. We are talking about PDA, being autistic, and food and the relationship with food and how we eat, how eating is hard, which that is a hard concept for a lot of people. But eating is hard, and it can be tricky. It can be tricky as a parent, kind of scary when we feel like we're not meeting that need of our children. If we feel like they're not getting nutrients or getting fed. And just like everything else with PDA, there's a huge perspective change that has to be taken. We're going to throw out all of the rules and expectations we've ever known and get some new ones, which is going to bring peace and happiness into our lives. So, Sarah, thank you so much for coming back and chatting with us on this part 3. You have so much amazing information for us. So go ahead and introduce yourself, who you are, what you do, how you're connected with PDA. That way, if someone is brand new with us, they can get a little idea of what you're all about.
Sure, yeah. I'm so happy to be back and keeping this awesome conversation going to talk about this really important topic that I feel like, is under-informed in the PDA space. So again, I'm Sarah Martin. I'm a registered dietitian nutritionist. I am neurodivergent myself. I am an adult identified autistic, PDA, ADHDer, a lot of the things. And I am also raising a fully neurodivergent family. So my spouse has ADHD. I have 3 kids who are all PDAers, autistic, ADHDers. So everything we talk about here on this podcast, this is real life for me. Not only do I help people with these things, but I am also living this life. And so I'm so happy to be back so we can talk about some really important things today that I think affect a lot of us in our families. So before we dive into that, I will mention you can find me on Instagram as @KindredNoodle, also on Facebook. Or to reach out to me directly, you can email thrive@kindrednoodle.com, just so everyone knows where to find me, because sometimes I forget to say that. And I feel like what we're talking about today is something that is so important that if anyone out there is listening and is needing support around this, I want them to know how to find that support. So,
and you do you do meet with families and individuals to support them. So we better mention that because you do work with families. And we are going to make sure to include all of your contact information in with the podcast details, get you connected in with our website because you are a really fantastic resource for the PDA community. One of the things that I love is you're not just showing up as an expert telling people what to do or what they should be doing. You're living it out and like, because there's one thing about like you can make suggestions and have good advice, and that's nice to have, but it's completely different if you have lived it and you know why it's hard, because sometimes things seem like a great idea in theory, but not always realistic with PDA. So we're going to start off today with a topic that I think lots of people have questions about. I know personally, like I have a ton of questions and it's kind of hard to track down the answers. And so this is all we're going to talk about ARFID. And so I'm going to let you first explain to us ARFID. Those are initials. So tell us what ARFID is.
Sure, yeah. So ARFID is an acronym that stands for Avoidant Restrictive Food Intake Disorder. So you'll often see it just abbreviated as ARFID, capital letters ARFID. And so ARFID is considered an eating disorder. And so this is a little bit different than, other eating disorders that we may have heard of, like anorexia nervosa or bulimia nervosa, where, there are associations with that are linked with perceptions of weight and body size and body type and things like that. ARFID is its own kind of thing where those things are not really factors. It's actually more about, the food. Restriction that is not necessarily purposeful restriction or with a clear cause behind it. So ARFID is something that, perhaps a lot of people haven't heard of, but they may have heard, things talked about like, links between autism and neurodivergence and what some people might refer to as picky eating, or what I like to call selective eating, or extreme cases of picky or selective eating. But ARFID is something that, goes a little beyond just being selective about our food. It's really when it gets to the point where it's having an impact on an individual's health in different ways. So we will get into exactly what that is. So with ARFID, a person might avoid eating specific foods, they might restrict the amount of food they eat, or they might avoid eating altogether. And then so because of that reduced food intake as part of this eating disorder, it can lead to causing real difficulty in meeting someone's nutritional needs. And this can affect people of all ages, all genders. I know often we think of other types of eating disorders and we might have, a specific age group in mind. Like we hear often a lot about teenage girls and eating disorders. And really with ARFID, this is something that can affect people across the lifespan, regardless of gender. So
is this something that we're going to think of? It's just sort of like popped up. It's just, you're just starting to maybe notice it. Or is it like, well, if they haven't been like this forever, then it's probably not. I don't know if I'm articulating this question very well, but in my mind, it's like, I can remember my parents being like, you used to love ketchup. And I was like, well, if I was a baby and you put ketchup on my food, I probably didn't have any kind of choice. But now that I have the choice, I am more selective in what I eat. So
is it, I think, is it like a sudden onset
or can it
condition?
be?
Or can it be? Or
So it can be. So ARFID, like I said, we can see this, really at any age and stage of life. And we'll get into kind of what the different types or manifestations of ARFID are, what those look like, and what some of the underlying causes can be. But generally, we will often see this in young kids because, we'll have kids that are seen as, extremely selective eaters, and it's causing them to not get enough nutrition, and they might be falling off their growth curve. And so, in their checkups, this is triggering like, what's going on here? We want to investigate this, or we want to get this child into some kind of treatment so that, they can get their nutritional needs met. So it's not uncommon to see this, especially in our autistic kiddos. Oftentimes we will see, very selective eating that can manifest into ARFID for a variety of reasons. But it is also something that can develop really at any point in life. And when we're looking at this through the lens of PDA and in the context of PDA, what we know about our PDAers is that our capacity and our function to handle different aspects of our life can be really variable. We have times when we might experience, as we've talked about in prior episodes, these contractions where we just do not have the capacity to access the ability and the skills and the everything that we need in order to nourish ourselves. And I won't get too much into that now because we did talk a lot about that in previous episodes. So, when we are seeing something like this, we might see ARFID happening alongside these, kind of PDA contractions, if you will, or lessening of that window of tolerance and things. Like, you'll often see during those times when if you're looking at the big picture, there may be other things that are going on that it seems like, everything is kind of shrinking down. There are all of these kind of restrictions or things like that we're seeing, and food is definitely one of those. And so when we're seeing that to a degree where it is now affecting the health, the growth, the psychosocial engagement with the PDA's world, then it crosses the line sort of being just selective eating. And when I say just selective eating, I don't mean to minimize that. I mean in terms of viewing this through like a clinical pathology lens. Mm-hmm. If someone is a very selective eater, which a lot of folks who are neurodivergent tend to be for a variety of reasons, this is something that I think is very, very common and kind of not unexpected to those of us that understand neurodivergence and understand where that's coming from. But when it becomes to a degree where this is affecting our health and well-being or our growth to the point where this is now a medical issue, then we're getting into the territory of this being an ARFID or a potential ARFID diagnosis.
So let's just pause right there really quick. So for somebody who's listening and you have an autistic or a PDA child, maybe you're autistic, ADHD, let's pause for a second and kind of break down this picky. That's what I was always called. I've always been called a picky eater. So let's kind of break down, what is someone who is a selective eater, and kind of like as a parent and you're observing your child, so when can I see, okay, my child is a selective eater and I'm going to support that? And then what am I looking for? What am I watching for when I go, okay, maybe this is actually something a little bit more. Maybe this is more serious. What are some of those things that I can be kind of mindful of to where like, okay, selective eater, we're kind of okay, or all right, this is crossing over into something more serious.
Yeah, so a selective eater to me is someone who is highly selective about what foods they eat, perhaps how much food they eat, where and when they're eating food, and of course, you know, this is something that is so unique and individualized, right? We of course, among every person on the planet, we will see variations in these things. No two people are ever like exactly in their preferences, exactly in the way they do things, exactly in what works for them. But when we're seeing this to a degree where, you know, I guess these kids that would have sort of been labeled as being, you know, quote unquote picky eaters, when they're selective with their food or how they consume it or what they're consuming to a degree where that's really noticeable or really out of sync with what perhaps is considered the norm for that family, that environment, that culture. And that's not necessarily a bad thing. I think, you know, the term selective, of course, is like, I prefer that over picky, because I feel like picky has such a negative connotation, whereas selective is like, you know, there's a reason behind this, and it's not just, you know, someone trying to be difficult, right?
So if you and I were meeting and chatting and I'm like, you know, I'm not, as a parent, I'm not quite sure, what are some of those things that you might be, what are the questions you would ask me, or some of the things that you're going to listen to me describe to where you're like, selective eater, like, keep on to what you're doing, or yeah, let's dig into this a little bit deeper. What are some of those like indicators where you're saying, okay, maybe this is ARFID? I always get ARFID. Okay, so what are some of those things that you might ask me, or the indicators when I'm describing my family, my child, you're like, okay, maybe it's something more.
Yeah, so I would be looking for any of the signs and symptoms of ARFID that are happening to a degree where it is apparent that they are affecting that individual's health and well-being. So common signs or symptoms of ARFID include being what would be thought of as a picky eater or an extreme picky eater, having a lack of interest in food, avoiding foods due to texture or consistency, refusing to try new foods, or requiring food to be prepared in a specific way, or feeling afraid to eat due to a fear of some kind of a consequence, like a possible allergic reaction, choking, or vomiting. And these would be fears that aren't necessarily things that would be true. So if we're thinking about, like, of course, a child with a peanut allergy, if presented with foods with peanuts, would be afraid to have an allergic reaction. That is not outside the scope of the norm. But when we're seeing, you know, something like, you know, these things that may be anxieties or fears that don't have a clear connection or basis, and when these things kind of get to the point where we are then seeing them affecting the health or the well-being of that individual. So a lot of the symptoms that I've listed off, I know are very common in our neurodivergent community, in our neurodivergent families. You know, I'm going through this list and I'm thinking like, yeah, my household deals with almost all of these on a daily basis. A couple of them, you know, maybe not all the time, but have been there at one time or another. So, you know, all of this can look different for every individual. It is very individualized. But what we're looking for are things, you know, signs like, you know, have they lost a lot of weight? Do they have, you know, what would be considered a really low body weight for their age or stage of development? For our kiddos, where we're tracking their growth on a regular basis, if they're having their checkups, you know, if we're seeing changes in what we would refer to as like falling off their growth curve. When we see them, you know, if they had been tracking in their growth in a certain pattern, and then we see a change in that pattern where we're either seeing, you know, that they are not gaining weight as expected or even losing weight, if they're, you know, not growing as expected. Obviously, these are really big signs. And then we're also looking for like signs of malnutrition, right? So like physical symptoms of malnutrition. So things like nutritional deficiencies like anemia or iron deficiency. If we're seeing things like fatigue or weakness that wasn't there before and isn't attributed to another known medical condition. If we're seeing things like dry nails or hair, that can indicate that we have a nutritional deficiency. Things like hair loss, trouble concentrating even can be one. And also for like those of us that are having this measured, and you don't always have this measured, but things like reduction in our bone density. So, you know, all these kinds of things that would indicate like, oh, there's some kind of a malnutrition going on here, some kind of a nutritional deficiency. And, you know, when we look at those physical symptoms along with what would be considered or looked at as more of behavioral indicators, which again, just signs, not causes. I want to be clear about that, and we'll get into why in a little bit. When I'm seeing kind of all of that in the same picture, or some of those things in the same picture, you know, that to me, and especially when we're seeing with our kiddos, you know, the weight loss, the falling off the growth curve, the stunted growth or not growing, or other signs of malnutrition, along with, you know, selective eating and parent reports of like, you know, they're concerned that they're not consuming enough food or consuming enough nutrients or things like that.
May I ask a question real quick? What about, is it possible for someone to have ARFID and be on the bigger side? You know, we've talked about like the weight loss is one thing, but can it go the other way? Like if you have that extreme restrictive of eating, but you do have a couple of safe things, is it possible to be a heavier person and still have ARFID?
Yes, it is. Unfortunately, a lot of it goes unidentified. Mm-hmm. But yes, you can have someone who is experiencing the symptoms of ARFID that is also displaying, you know, symptoms of malnutrition, mm-hmm. and they can be overweight. Thank you for bringing that up, because that is kind of a big myth out there that, you know, if someone isn't underweight, then they can't have an eating disorder, or they can't have ARFID, or they can't have malnutrition, and that's absolutely not true. Body weight is only one of the things that we look at. Like we just went through that whole list of, you know, mm-hmm. signs and symptoms, and that is just one. And unfortunately, that is typically the most common indicator that there is an issue. You know, when we see weight loss or lack of weight gain or things like that, that is one of the most obvious things, and especially because that is one of the most highly tracked things
Sure.
in our healthcare system. But it is absolutely possible to be experiencing ARFID or ARFID-like symptoms and be overweight or be of normal body weight. Yes.
Okay. Thank you for clearing that up.
Yeah, of course.
Such a good question, and so valid and really overlooked because, a child who is overweight but if they have only a couple safe foods, and when we talk about safe foods, one of the things, texture or a really, really important thing for autistic people on safe foods is consistency. And so that's something that we see a lot, that you want to know what to expect. You want to know exactly what you're going to get when you're eating, which means things like a bag of chips. That bag of chips is going to be exactly the same every single bag. It can come from different stores, but if it's the same flavor and the same brand, you're getting the exact same thing and you know what to expect, and that's comforting. And I think that's also the draw to like fast food. So if you're going to a fast food restaurant, you can go to it anywhere in town. If there's a couple locations, you can go out of town, go to that same place, and you know exactly what you're getting. It's the same everywhere. And so I think that's an important piece of selective eating, is you want to know what you're going to get. And that could be textures and flavors and all of those things. And so to me, in kind of how our culture and society is, fast food is actually very safe. One, it's tasty, it's quick, and it's very reliable. But it's also, in some of it is not nutritious. So that would lead into weight gain and malnutrition. And so I think that really goes into what we've discussed before, in like, why does someone do what they do? So it's not about being picky or lazy. It's about consistency, knowing what to expect, executive functioning, like
Safety.
yes, it's that safety and that comfort, and that's such a big part of our food. And if you buy a bag of lunch meat from the deli, it can be different every time. And so then not only are you talking about executive functioning and you have to build the sandwich, we have inertia. You have to stop what you're doing, get up, do the things, put it away, planning, organization. But then it might not turn out to be exactly what you want. And then comes avoidance or defaulting to, I know this bag of chips is going to be exactly what I need. And so I think, that kind of plays a huge role in that selective eating.
Yes.
And like, I can see that in my own life, in like, Scott, like, I want it to be a certain way. And for me, I'm actually very anti-fast food. And that plays in, though, to my OCD. And so, like, taking those things into consideration as well. Am I a selective eater? Like, why is that happening? For me, a lot of it is about OCD. And so I think those are important things to consider as well when we're looking at why a person does what they do. But I'm glad that Heather mentioned weight is not the most important indicator.
Yeah, absolutely. And Kerissa, everything that you just said, absolutely. Like, hit the nail on the head right there. Like, yes, there are so many things that go into this. And for so many of our kids or individuals or families that are dealing with this, yes, things like fast food or the consistency of processed food and knowing what to expect and knowing what that is and finding comfort and safety in those things is a very common experience for so many of us.
I used to consider myself a very having a wide palate, wide range of liking food. But then when I was diagnosed ADHD, and when I realized I'm most likely autistic, and started unmasking, my tolerance for being able to eat a very wide variety of food narrowed significantly. And my husband calls it now, it's like, if we order something or if I'll make something or something like that, and it's just not the way it needs to be, he goes, "Oh, you're having food disappointment again." So that's what he calls it instead of picky eating. And then I didn't realize the emotional effect it would have on him, that he would have anxiety around what I was able to access. And so, we had to work through that. It's just like, no, it has nothing to do with, a lack of understand. It's me, it's all me. It's not you, it's me. But I honestly did not realize, even as a parent of a PDA with a very, narrow palate for himself, and I know the anxiety that I would go through making, like, oh, is he getting enough? Are we getting enough of this and that? That I was unintentionally causing the same anxiety on my husband because of what he calls my food disappointment.
Yeah, I think these are
it's so
really
interesting. It's so interesting.
Yeah, really, really relatable experiences to a lot of us neurodivergent folks, that this is really common. And so, when we talk about kind of what is typical for us folks that are neurodivergent in terms of our eating, our food preferences, our eating patterns, things like this, you will see kind of so much divergence from what is considered typical eating, which doesn't necessarily mean that that's a problem. And, we certainly should be looking at these things through the lens of, are we potentially over pathologizing some of what is, the norm for neurotypical folks, certainly. So when we see things like that, that to me sounds very typical of a neurotypical experience, of a neurodivergent experience. But to me, I'm listening to you say this, and I'm not really hearing any red flags that are going, oh, she's got ARFID eating disorder,
No.
I think I'm just pointing this out as like a distinction of like, if folks are out there thinking like, oh my goodness, I experienced what you described, do I have ARFID? Well, no, not necessarily. I think we need to be aware that like a lot of us are likely to have different ways of eating or feeding ourselves or needing to be fed, and that's okay. That is totally okay. We've gotten into that in the prior couple of episodes a little bit. But when we're looking at ARFID, when these things are collectively getting to the point where it is actually affecting our health and well-being, and I want to be clear that that is not only our physical health, but that's also our psychosocial health. So when perhaps even if we are physically healthy and we are not experiencing malnutrition, But we are experiencing such an impact on our daily life because of this that it's restricting our social activities, it's restricting our ability to participate in things that we would otherwise want to participate in. For instance, if our food restriction, for whatever the root cause is affecting our ability to go to a restaurant and be there with our friends if we want to do that, then, it's things like that, like, are we not able to kind of live our lives because of what's happening? And again, looking at the context in PDA, of course, this is always, to me, through the lens of something that the PDA would desire and want to do. Not just you're like, oh, we should make everybody go eat in a restaurant or whatever. No. So from that, I do want to branch a little bit into just talking real quick about the different types of ARFID and how that can present and what that looks like and what that means. So there are 5 different types of ARFID that are like clinically identified. The first one is avoidant. And so with that type, that's when we're seeing restriction due to sensory needs. So if there's issues with texture, smell, color, flavor, presentation of the food, things like that, things that go along with our sensory experience of that food that is causing avoidance of that food, it falls under the avoidant category. The next one is aversive. So aversive is for those folks that are avoiding foods because they have anxiety or fear around what might happen if they consume that food. So common things with that are things like fear of having an allergic reaction, fear of choking on a food, fear of vomiting. So if someone has an aversion or fear of vomiting, they may choose not to consume food if they think it's going to make them throw up. And so, a bit different there than the avoidant type, even though those two words, avoidant and aversive, sound very similar. Then there's the restrictive type. So this is when we see someone that appears to have little or no interest in food. So just like, not interested, I'm not hungry, perhaps they are not able or connected with like sensing or experiencing their internal cues of hunger and fullness and things. When we see that, we're having challenges with our interoception, which is that all of those senses that tell us, what is going on in there and what do we need. And also, just, that, so those folks that are like, I'm not hungry, but there's, perhaps no identifiable like root cause there, like with our kiddos that have, that are sensory avoidant, right? Where we can see like, oh, this is clearly about the texture of the food or this or that, the restrictive is more like, but it's not like with, when we see someone with anorexia, eating disorder, where it is restrictive, but it's restrictive with a certain purpose, right? There's something tied into that where this is restrictive, not necessarily for the purpose of, weight loss or body image or things like that. The fourth type is adult ARFID. So, a lot of these other types, are identified in childhood. We often see these as kids are growing and developing, and when we're noticing, some of the things we talked about earlier. So adult ARFID, it kind of gets lumped, under, like, you're an adult and you're experiencing these things. And then the fifth type is called ARFID plus. And really all that means is that an individual is experiencing more than one type of ARFID at once. And so, for a lot of our neurodivergent, particularly autistic and PDA kiddos, where we're seeing, yes, there are sensory needs here, right? So they may be avoidant of certain foods because of sensory, but then there may also be like an aversive component there. So when we think about our PDAers, especially with that tie into anxiety. So when we're having anxiety over things like, I'm gonna eat that food and it might make me sick, kind of things, you know, but also there are some foods I just avoid because I hate squishy texture or something like that, you know, we can see that. Or even, you know, the restrictive type where they may not be able to have that sense from their bodies of when they need to eat or what they need to eat or how they need to eat. So ARFID Plus is really just when we see more than one type of thing going on there. So we do often see, I'm just trying to bring up my notes on this part, that there is a connection here often between ARFID and neurodivergence. So it is seen a lot with people that have ADHD, that have OCD, that are autistic, and also that experience anxiety. And so, you know, there's kind of this, a lot of sort of like overlap here, right? Mm-hmm. Of what we see of signs or symptoms or what appear as outward behaviors of all these different things that can affect our eating. And so, you know, not so surprising then when we know what we know about neurodivergence and when we know what we know about autism and PDA, that this is a really common thing that is experienced by PDAers and by individuals and families living with PDA.
So how do we go about treating ARFID?
That's an excellent question. There are different ways of going about this, and some are more PDA friendly than others. So often, you know, when a child is identified as having ARFID, depending on, you know, what type is identified or what is going on in terms of their physical health, you know, you might see people getting referred to GI specialists, dietitians, speech language pathologists, occupational therapists, or often in the case of kids, you might be referred to what's called a feeding team or a feeding clinic, where it's an interdisciplinary group of professionals that help treat and support feeding needs. So there's different approaches, different ways. There are methods that are based in kind of rooted in behavioral modification type things, so ABA type practices where the emphasis is on changing the behavior through either, you know, a reward or consequence, incentive or disincentive. And, you know, a lot of that is just focused around what the observable behaviors are. So if we have a kiddo that, you know, is food avoidant, and let's say every night at the dinner table is a struggle to get this child to consume any food, if this child is referred into a therapy of that type, they might be looking at methods that are trying to encourage the child, in best cases with rewards, mm-hmm. and in worst cases with consequences, to change their behavior around eating, which that, you know, target behavior would be getting them to consume the food or X amount of food or X amount of bites of food or things like that. So when we look at these types of therapies, what the evidence shows is that they can be effective in the short term in terms of increasing food intake. But when we talk to families that have experienced these types of therapies, there are real concerns with the long-term impact, right? Because if we're looking, in clinic, we're using these techniques, methods, things that to me often feel, as a PDAer, to me would feel very coercive, of trying to get someone to eat without really addressing the underlying issues. And that's
So
not
you're talking
Yeah.
specifically about the behavioral
Yes.
approach,
Yes.
the ABA approach.
Yes.
Let's shape the behavior through reinforcements.
Yes.
That okay.
Yes.
Which is probably not the best course, the best type when we are talking about PDA, autism.
Yeah.
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 But this is going to be, we'll just call it like the typical or standard approach that as a parent you're going to experience, which I think it's important to, as PDA families, it's important to know and to understand when you go to seek help and when you seek out others and advice and instruction and guidance. We want to know what is sort of that standard, typical recommendations that you're going to get. So I think that it's important for us to know.
To talk
What-
about that part.
Yes.
So we know what somebody's going to present to us. And then go back and go, okay, well, what else is there?
Or how can we adapt the standard or typical procedures? How are we going to adapt that to meet the needs of PDA or a anxious avoidant individual? So because personally I want to know what to expect. I want to what is like standard protocol? Let's hear, let's hear that. I want to know what that is, because in my mind, I'm always having to say, okay, I'm going to take what this person is telling me. Mm-hmm. And in my mind, the entire time, I'm breaking it down, reformulating in, okay, how am I now going to take your expert opinion that probably works for someone? How am I going to now shift it so that it actually applies in my life? So let's continue on with what is, I go see somebody, I'm worried about ARFID, I'm meeting with someone, they're going to make recommendations. What is going to be that typical standard response of this is what you should do? And we're talking now about ARFID, and we're under the understanding that we're having an ARFID conversation, not my autistic child is a picky eater. So we've already progressed. What is it that I can expect a professional to tell me? And then let's break that down into, what does that actually mean for PDA? What's the real deal in that? What's gonna actually help without actually causing more harm?
Yeah, that's a great question. So in this case, I would say there is an amount of variability between approaches to feeding therapy for ARFID. So a lot of it will depend on the expertise of the team or the provider, what types of training they've had, what their background or scope of practice is. So for instance, my scope as a dietitian is a bit different than what a speech language pathologist would be doing, or the lens that they would be looking at everything, or an occupational therapist. You know, we each kind of have our different areas of focus, right? But we do have certain areas that also overlap. And so it may depend on the type of professional that you're seeing for this issue. And if you're seeing an interdisciplinary team, this may depend on the clinical standards of their particular practice, their particular hospital system, which there can be some variation. I mean, we do have, you know, across the board professional standards for all licensed healthcare professionals, but there can be some variability depending on the different types of training and different understanding that these providers have of ARFID itself, of neurodivergence, and kind of what lens they are looking at. You know, if you are seeing a provider or a team of providers that have been trained through a very behavioral view of autism that perhaps has little to no awareness of PDA or does not recognize PDA, then that can be very challenging. You know, if you're going in and you're bringing your child in for therapy and the system that they're working within is built around, you know, rewards and built around trying to encourage an eating behavior or encourage increased consumption or encourage increased variety of food intake in a way that is not intrinsically motivated by the individual. So if the motivation or the pressure to do these things is external to the individual, which it often is in these systems, we see this not only in these types of therapies, we see this throughout our educational system, all of that. You guys have talked about this extensively in so many of your episodes, so I know you're both experts on all of that and totally get that. So it can really depend on that type of training. So there are other ways of looking at this, and one that I love in particular is called responsive feeding therapy, or RFT. So responsive feeding therapy is more focused on the individual and the unique set of circumstances around their health and their life and all of that. It is designed to take into account all of the factors of what is going on that are contributing to the ARFID or the food avoidance or the selective eating that we may be seeing. So not just kind of, you know, wanting to focus on behavior modification, but really focus on how do we support this individual so that they can get their needs met in the context of their eating, feeding, food, nutrition. So RFT focuses on 5 values: autonomy, relationship, competence, intrinsic motivation, and holism. And I want to note that there is this amazing white paper out there at responsivefeedingpro.com. The creators of this approach to feeding have done a wonderful job putting this together. There's so much information. So if we have any healthcare providers or practitioners out there that are listening and want more information on this, You can find it there. There's so much information there. There's also online trainings that I have done. This is how I learned about RFT. They have, on demand 24/7 trainings that you can access from anywhere in the world, which is awesome. And so, getting back to this, so what I'm sharing right now is coming from Responsive Feeding Pro and their white paper, this information. So,
Well, and you just said a few of our absolute most favorite
Right?
words, right?
And the expression on your face, I mean, when you started talking about responsive feeding therapy, your entire demeanor changed. For those of you who are just listening to us and you're not watching us, it was just this very noticeable shift. So I can see the joy that this brings you, and professionally, and talking about it.
So autonomy,
really,
our number one most favorite word in the PDA world is autonomy. So the fact that in this type of, we'll call treatment, support, accommodation, the first word you use is autonomy. Yeah, so many green flags, like, yes, autonomy. Next, our other most favorite word was relationship. And so we know some of the key things with PDA is autonomy and relationship. And so that tells me, along with a big smile on your face, that when you're leading anything that has to do with PDA, if you're leading with autonomy and a relationship, like, we're headed in the good and the right direction. And I couldn't even help be excited. And I was like, yes,
Right.
yes, autonomy, relationship, okay,
yes.
yeah, I'm on board. Let's go. So
Yes.
continue on. We will make sure to share this resource about this program for anyone who wants to learn more about it. But yeah, anything that leads with autonomy relationship is going to get all the thumbs up from me and Heather. So yeah.
Yes.
All right.
Yes.
Continue.
And
Sorry, we interrupted, but we were both very excited.
oh
Yes.
yeah,
Right?
I'm excited.
You were excited, I was excited, Kerissa was, we were just all excited all at the same time.
Yes, because this, I think, is so refreshing for so many of us that have encountered things that are intended to help support our families, but that are not PDA aligned and really do not understand the unique needs of our PDAers. And so when I found responsive feeding therapy, I was looking for something that would help our kiddos and families that have ARFID, that are dealing with ARFID or selective eating, to the point where their families felt like they needed help with this. And a lot of what I was finding were behavior-based approaches. And, I would look at those and I'd be like, that will absolutely not work for my kids that are dealing with ARFID and selective eating. And I know that that won't work for a lot of other PDAers and other families. And so when I found this, it was like, yes, this big aha moment of somebody out there gets it, and they're writing about it, and they're researching about it, and they're training providers on this, and they're making this accessible to us. And so it absolutely, made me feel so awesome to come across this. And especially, again, that first thing being autonomy, which is so key, and then relationship and competence, right? So those first three things, those are kind of the basic needs that then are necessary for us to have intrinsic motivation to do something, right? So if our needs for autonomy, relationship, and if we have a sense of competence in our ability to feed ourselves, then we will then develop this intrinsic motivation that will then help us find the ways that we can nourish ourselves or be supported in nourishing ourselves. And then that fifth one, the holism, so that's, holistic, meaning like full picture, right? So we're looking at the whole child or the whole adult or the whole individual, through which these other values are applied. So we're looking at this not only in the context of like our goal of like helping someone meet their nutritional needs, but we're also looking at this in the context of what are all the things going on for them that are either influencing or influenced by what we're seeing here or the issue that we're trying to approach here. So there are 3 core goals that go along with responsive feeding. The first is to prioritize felt safety and nervous system regulation, which, amen to that. We talk about that so much in the PDA space. We've talked about that a lot in our previous 2 episodes on eating and feeding. And so for that to be number 1 goal is awesome. The second goal is to support and optimize children's relationship with food and their bodies. So this is really helping the individual to establish and cultivate their own relationship with their body, their health, their food, their eating experience, and what they need in all of that in order to be nourished. And so we're looking at, within that, what barriers are we considering? Are we having issues with interoception, proprioception? Are there physical limitations to what we can do in order to nourish ourselves? Things like that. And then the third one, the third goal is to provide individualized care. So again, thinking in the lens of PDA, the key word there is individualized. So we're looking at the person as an individual. What are their individual needs? What individual supports do they need? So when we have, respected autonomy, when we are supporting relationship, when we are fostering competence, and when we are combining all that together to promote this intrinsic motivation and then seeing everything through that holism lens, that full picture, it has to be highly individualized, right? So that is built in there. There is no one size fits all approach. This is a very personal thing. So providers that are working in responsive feeding therapy are recognizing that what works for one individual or one family is not going to be the same that works for everybody else. We're not trying to get the individual or the family to fit this certain mode or model of care. To say like, oh, you have to do things this way, or this is how everything works. It's really looking at everything together and seeing what's needed, and then taking a very collaborative approach on how we get there.
I love the collaborative approach. That's what's going to motivate a PDAer. That's what's going to build that value in them, is when they have, one, the full information, like, why do we care? Why is this important? Why are we even trying to make changes? And then involving them in that collaborative. And the thing is like, as a parent, I can get a recommendation of like, hey, this is what you should do and how you should do it. But then actually implementing that in my home is a whole different thing. And so for me to feel like I'm going to be able to collaborate with a professional, that's what's going to make the difference in whether we're going to actually be able to make changes. I need to be able to feel like I can go back and say, hey, like, this isn't working. I don't understand that. Hey, here's something that I did find that works. And to be able to get that collaborative feedback. And like, that's what, to me, that's one of the things I'm looking for when I want to get support or guidance from a professional. Like, collaborate with me so I can collaborate with my child so that we can actually make a positive impact on meeting their needs.
Yes, absolutely. Yeah, and I see this from both sides, as both the provider and the parent. In that, for me too, the collaboration, of course, is so important. And it also fosters this foundation of trust between the individual, the family, and the provider, so that, I know as a parent that if I'm working with someone who is trained in responsive feeding therapy and following this guidance and these practices that are laid out here, that I can trust that if I go to them and I say, we worked out a plan last time we were here, and I went home and we tried some things, and here's what's working, or here's what's not working, or here are my concerns, or all of this, I can trust that we can have a real conversation around that, and that I will be believed and trusted.
Yes.
That
Yes.
I know my child, and that I understand, and I am competent in my observation of what's going on. Whereas I feel sometimes in some aspects of clinical or medical care, we don't get to experience that as parents. Very often we'll say, I went home, I tried this, I did this, it's not working for my child, here's XYZ, like, here's the examples, and they go, oh, you're not doing it right, or, oh, you just need to try harder, or do more, or you must not be telling me the truth, right?
Or you're not actually being consistent.
Or non-compliant. Patient
Yes.
is non-compliant. And
Yes. And, I think those things can happen, like ooh, that word non-compliance, right? That feels like such a loaded word, but I feel like, to me, if someone is coming to me and I see that they're non-compliant, and I'm using quotation fingers around this, is that my question is always, why?
Why?
What's the underlying cause
Yeah.
here? Like, what are the barriers in the way of them being able to comply with this? To me, it is usually not that a person doesn't want to, or is lazy, or is any of these things that we think of when we hear the word non-compliant, right? Like that they're just not doing what they're supposed to do. Often there are other factors going on there of like why they could not do this, or why this was not accessible to them, or why this was not a realistic expectation of me as their clinician. expecting this. So to me, that just opens up further curiosity of like, okay, this didn't work. Let's find out why. Or let's think about what might work differently that would help us achieve the same goal or the same end result, but that is also preserving that autonomy, that bodily integrity, that respect, that relationship, right? Because for me, I never want to see any family in a situation where something is happening under the advice of well-meaning professionals that is making a child feel unsafe in any way, that is compromising their bodily autonomy, that is, making them feel like they are not allowed control of their own body. I never want to see something where a family relationships are at stake, or stressed or strained, or there's trauma around these things because a parent is trying to be compliant with the advice of a professional at the expense of the relationship with their child. I don't think that you need to be that way in order to get the results that we need in order to support that child's health and well-being. And again, we go back to this when we talked about, some of the behavioral approaches, and where, yes, we see short-term successes with these things. Yes, we might get them to eat some things and we might see a little bit of weight gain, but is this sustainable in the long term? And often it's not. Often it's not when we are using methods or practices that are undermining that autonomy and that are damaging to those relationships. And so, yes, I might be able to get my child to eat more by being really strict and forcing them and not allowing them to have their preferred foods until they eat the food that we are choosing for them to eat based on, our assessed nutritional needs. That, okay, well, what's gonna happen down the line? 6 months, a year, 5 years, 10 years, when we're looking at this parent-child relationship and this child looks back on their childhood and so much of that was this stress and strain around the dinner table. And all because the parent who loves and cares for their child so much is just trying to help them. But they aren't being given the tools and the means and the support that's appropriate for their child and family.
Yes. Yeah.
Hear, hear.
Yes.
Yeah. and that goes back to the relationship. And I'm just like laughing to myself because my son is a very selective eater. And a big reason for him is he just does not ever feel hungry. And so one of the things that I started doing is like, I encourage him to eat a preferred food first and then get into something, more calorie dense, or, he only eats preferred foods, but like some are more preferred than others. And I'm just laughing because just yesterday I gave him a gentle reminder, like, when was the last time you had something to eat? And he was like, I don't know. And then a few minutes later, he comes out and he's sitting on the couch and he's eating a gluten-free, dairy-free ice cream sandwich. And that's just like, that's what we do. That's just standard. It's established. Eat the ice cream sandwich because he probably hasn't eaten in a very long time. And so, yeah, have your ice cream sandwich, hang out for a minute. And then he actually made himself a gluten-free pizza. I think he ate the entire pizza. But he did it in his own time. He was wearing earbuds. I think he was watching YouTube. But he also prepared it on his own and was, fed. But in order to get to that point, he had the ice cream sandwich first. And so that's just something that we do. And I kind of laugh because it's so untraditional, very untypical. Usually it would be like, you cannot have any ice cream until, and so for us, flipping it actually makes eating so much easier, and it's so much easier on my relationship with him as the parent, because we're not fighting, we're not arguing, I'm not making up all of these rules, and the end result, which is really what matters, is he getting calories? Did he eat? And so then I'm like, yay, huge success. So I'm not going to worry about where the ice cream sandwich, what order it came in. And then he has autonomy. Our relationship is good and solid. He's comfortable, he's happy, and he had his food. And so to me, that's success. I would imagine that if I went and talked to, somebody else who is not familiar with autism, and this is not even my PDA, this is my just very anxious autistic child, I probably would get some criticism for this method, but to see our home is peaceful, and my child is eating, and it's not putting a strain on our relationship or the family. And so we do not have any rules about when you eat ice cream or cookies or any, there's no order. The order is the order that you choose, and that works for your body. And that's how we go about. And it's still something I do have to check in with him still, and he's still learning some of those things about how to make sure you eat even when you're not hungry, but not having that strain or that conflict is so important to us.
I love that example. That is such a great example of, something that if we were working together, right, you and I and your child, on their feeding and their nutrition, of coming up with something that works, that helps, that makes that accessible. And I think that is such a beautiful example of doing things in a different way, but doing them in such a way that it is supporting your child's unique needs. And so when I'm thinking about scenarios like the one you've described, and I'm trying to make it relatable to people that might not be as familiar with PDA or familiar with these types of approaches or concepts, I like to think of the analogy of having a life jacket on, right? So if we think of eating and feeding food and things as our swimming pool, and we have a kiddo that can't swim, right? Our kiddos with ARFID are our kiddos that can't swim. We're not gonna get them to learn how to swim by just throwing them in the pool and being do it. Work harder and you get to earn to get out of the pool, and whatever. But instead, in this instance, having him have his ice cream sandwich, even if it's before dinner, even if it's not what we would consider the most nutritious thing, is that life jacket for him, of he is entering that pool of meeting his nutritional needs, of eating and feeding, and he's got his life jacket. It's that ice cream sandwich. That ice cream sandwich in that moment is what is making that accessible to him. He feels safe with his ice cream sandwich, and so we never want to compromise that safety. And he also knows that you're right there, and you will be putting things into the pool maybe for him to encounter, and he can, with the safety of his life jacket, choose what he's doing in that pool. So I think to a lot of people, they haven't thought about it in that way before, but it really is you're making this accommodation, this necessary accommodation for your child, when the alternative is that they don't eat. If it's ice cream sandwich or don't eat, I'm gonna pick ice cream sandwich every time. Every time.
Yes.
And so when I have a parent that's coming to me and they're saying, this is all they eat, or they only eat, these few foods, of course, we're not going to mess with that. We don't ever want to take that away. We don't want to take away their life jacket, right? Those things right now are their life jacket. That is literally what is keeping them alive. And I'm experiencing this. I know I've talked about this in past episodes with my youngest child, who can only at times consume a selective few number of foods. And right now we've seen some expansion, some contraction. Right now we're in a little bit of a contraction where our primary food is Reese's peanut butter cups. And, you know, are they ideal in terms of meeting all the nutritional needs? No, of course not. Do they provide some of what my kiddo needs? Do they provide calories? Yes. Do they provide a bit of protein? They've got peanuts, peanut butter in them? Yes, there's something in that, right? And so I'm looking at this from the perspective of like, okay, that is my child's life vest right now. Reese's peanut butter cups. So no matter what, those are stocked in my house. We have those. And those, like you were describing with the ice cream sandwich, like for my child, those are often the gateway to the mealtime, is that they need to start off with the safe food. And then consuming the safe food is then helping my child recognize their own hunger cues. They eat a peanut butter cup and then their stomach goes, I want more food. And then they go, oh, I am hungry. I do need to eat something. And then we have made food available for them. And so then they are choosing among that food what they want to eat, or if they're eating more peanut butter cups or whatever it may be. But then they're able to broaden their intake. They're able to broaden their variety of food. They're able to broaden the amount of food that they're consuming because they have their peanut butter cup, because they have that life vest. And
Yes.
if I were restricting that, if I were saying, nope, you cannot have a peanut butter cup until, you know, you've eaten your chicken or something like that, then they would starve. They would starve because they can't eat the chicken until they've put on their life vest.
Yeah.
Until they've had the accommodation that makes that accessible for them.
Yes. Well, and, you know, with the swimming analogy too, like, you're going to probably be in the pool with them. And so you're going to hold their hand, which means, like, my son learned that it's okay to eat that ice cream sandwich first, because I ate ice cream sandwiches with him when he felt like he couldn't eat anything else. And he's like, I'm not hungry and I don't want anything. And so I sat with him, and it's like, and that's also breaking down that shame or that embarrassment too, that he's feeling of like, I am not doing the right thing, but I also can't do anything different. And so, yeah, we started eating ice cream sandwiches together. And then it was, I had an ice cream sandwich and then I made myself a sandwich. And then he ate probably a corn dog or frozen pizza. And so, like, doing it together, we talk a lot about when you want to teach an autistic person or a PDA person, doing it through modeling is a great way, especially with PDA, because you can't say, hey, you need to do this, this, and this. Immediately they're like, I cannot. So letting them observe me walk through those steps is what breaks down that shame and helps to allow them to engage in that same activity. So if I'm going to have a little snack before I have dinner and they see that, then it gives them permission to do the same. Which also, if you think about, we always have appetizers before a big meal. And an appetizer is something small and tasty and really great, like chips and salsa before you have your, you know, big taco dinner. So I look at it like, this is just our appetizer, and then we can get into that full meal. But that's something that I modeled for my kids. And yeah, it's also like, I just sort of like get ideas and have food around, and just like, maybe you want to try this thing, maybe you don't. We also have the rule of, if you don't like it, spit it out. Like, nobody's required to like choke it down or gag it down. If you don't like it, just spit it out. Be done. You don't have to finish it. And that, I think, builds that relationship and that trust as well. And there's no shame, there's no guilt that goes along with those things. One of the things that we accidentally came upon for my kids, they love to eat frozen fruit. So like it's rock hard. They put it in a bowl, and they usually like to take it to their room. I think my daughter probably eats it right out of the bag. And I think there's sensory things that go along with that. We live where it's very warm, so I think they like the cold. And so here we are, every mom's dream is that their kid eats lots of fruit. And my kids wouldn't eat. They don't eat hardly any fresh fruit. My son does, I guess, but turns out a gigantic bag of mixed frozen fruit that they can eat any time, day or night, is something that's hugely accessible for them. And I'm like, wow, look at, like, you're eating a 2-pound bag of fresh fruit or frozen fruit every week. I never dreamed that they could even eat that much fruit, but by doing it just in this really different way. And now they're getting all the nutrients and they're eating fruit. And I would never chomp down on a piece of frozen fruit. That's not my preference. I wouldn't like that. But like, here my kids love it. And so, yeah, kind of thinking outside the box and allowing something way different or something I wouldn't do, just like opens up so many possibilities.
Absolutely. Yeah, I'm listening to all of this and I'm just internally like, yes, Kerissa, that's awesome. And I'm just thinking, I'm like, you are intuitively practicing responsive feeding with your family without probably even knowing what that was. But yes, exactly. Yeah. That modeling the accommodation, the centering it all around your child's specific needs and not a set of outside expectations is amazing. That's amazing. So, like, huge bow to you for doing all of that, because I know from experience as a parent how difficult all of that can be. And we've talked about this in the last episode, when we have kind of our own sets of expectations and things around food and you know, food practices and beliefs that we are kind of having to undo in order to accommodate our kids. So that's huge. Like, all of that is huge. And the fruit, that's amazing. Like, finding something that worked for them, you know, that's awesome.
Yes, yeah. We have done a lot of breaking down of the really traditional expectations around food, and really just creating our whole own approach. And it's so individual, which that traditional idea of like everybody in the family eats the exact same things, and realizing that absolutely does not work. And so in our family, when we started to be like, well, each individual, all 4 of us, need something really different, and then going like, yeah, why can't we do that? Why do all 4 of us have to eat the exact same thing? And that was life-changing for our family. And I think that is really about that responsive feeding, is we're just giving each individual exactly what we need, you know, and thinking about me and my husband, right? So like adults, but my husband needs completely different like nutrients and calories and preferences. His body needs way different than what mine does. And so then why would I think my children should be eating exactly like I am? It just doesn't make sense. And so once we kind of started to branch out and like, actually, all four of us can eat completely different meals. We can also eat at different times and different quantities and in different spaces. Then it just brought a whole new level of like peace to our family. And it really did help the whole family dynamic and that relationship of, I don't want to force, I'm not about forcing anybody to try and eat anything against their will. Like, that puts too much pressure and strain on me as a parent. And I'm like, I got enough to worry about. Have an ice cream sandwich.
Yeah, amazing. So, I guess to tie that into the context of responsive feeding therapy, and if a family were seeking support from or working with a responsive feeding therapy provider, I mean, these are the kinds of things that this provider would be helping you and your family with. So identifying those different needs, identifying, what in terms of your resources is accessible to your family. So in terms of things like time and budget and, parents' capacity or energy level to be providing these things or accommodations or working with their children in a certain way. Again, that goes back to that looking at the whole picture. And so it's very, very individualized. I am looking at the time here, and I noticed that we've been talking about this for quite a while, which is awesome. And I've been so excited to be here and sharing about all of this. But I am thinking that I want to make sure that I leave everybody with information on what to look for if they are thinking that their family or their child would need or would benefit from feeding therapy support. So obviously through this whole episode, you can tell I'm a huge advocate of responsive feeding therapy. It's wonderful if you can find a feeding team or a practitioner. So either a dietitian, an occupational therapist, a speech-language pathologist, or other type of allied healthcare professional that provides support around eating and feeding that has training in responsive feeding therapy. That's ideal. So if you can find somebody with that, that's a good question to ask. Are you familiar with responsive feeding therapy? Are you trained in responsive feeding therapy? Or what is your experience or background with responsive feeding therapy? Are the types of things you could ask. If you are limited either by insurance or geographic area or other factors in terms of your access or selection of providers, one thing that I like to recommend is if you are seeing somebody that either does not have training in this or is not familiar with it or may have heard of it but isn't quite sure what to do with it or anything, don't be afraid to print out this white paper from Responsive Feeding Pro. So it's responsivefeedingpro.com, and I have no personal or direct affiliation with them. I don't work for them or anything like that. This is just a resource that I have found immensely helpful. Take that to your provider and have a conversation with them about your goals for your child in the context of responsive feeding. And hopefully, in an ideal situation, you might be able to get that provider on board to work with you in that way, collaboratively. But again, that's something that, for some providers might seem a little outside the box. It might not be something they're trained in or familiar with, so it may not be unusual if you're their first patient or client that is coming to them and saying, I want to work with you in this way. So again, and that's if you're not able to find someone that's accessible to you, that does have this training, there are certainly ways to kind of help work that in, even in a more typical or traditional therapy setting. Also, always important, and we know this with our PDAers across the board, whether it's feeding and eating or anything, any kind of therapy, any kind of support you're going to get for your child, you always want to understand what's going to be happening, what the goals are, what methods are used, what types of things you are going to be expected of your child or of your family. Always important to have that understanding before you are entering into any type of treatment or care. I say this because I know for a lot of our families, by the time that they are looking for care providers, often it's when things feel very urgent or desperate. There is a clear need, there is a clear problem, and as a parent, I have gone through the experience of trying to access care for my child, but also not necessarily being aware that I had a choice or that there are different approaches out there. So I want to make sure that all of our listeners, that if this is something that you're looking for, that you're aware that you have choice, that you're aware that it's okay to ask your provider to learn about something if they don't know about it already. Because I think from the provider side, most of us get into these professions because we truly do care about our patients, our clients, our families that we're working with. We truly do want to help. And sometimes it takes us time to find, what is going to be most helpful, or it takes us time to learn. Or with things like responsive feeding, maybe it's not something we have encountered or learned about before, and that does not mean that we would not be open to learning about it. I know from my perspective as a provider, if someone comes to me with something and I haven't heard about it and they're like, oh, I'm interested in this or I'm interested in that, that just sparks my curiosity of like, oh, what's going on with this? And then I can learn about it, and then we can have a conversation and see if that is something that is first within my scope, and second, that I would have the ability or the competency to support them with. So never be afraid to have those conversations with your providers. And I know they can be sometimes difficult, sometimes challenging, especially if we're asking for something that seems different from the norm or different from the typical. But part of my purpose in being here today and my mission in talking about this is to raise awareness about responsive feeding therapy, to raise awareness that there are alternatives to behavioral approaches to supporting our children, our adults, our individuals, our families in meeting their nutritional needs.
Well, you are just absolutely fabulous. You have so much knowledge and so much compassion, and we just can't even thank you enough for sharing all of this with us and encouraging people to be curious and knowing questions and how to advocate. So thank you so much for being here and chatting with us and sharing all of your knowledge.
Thank you so much for having me. It's been a pleasure as always.
And if you would like more information about PDA or pathological demand avoidance, you can find us at journeyswithpda.com. We are on Facebook and Instagram. You can also email us at journeyswithpda@gmail.com. And I will put all of Sarah's contact information in the episode description.
Yes.
Thank you so much.
Thank you.
Yep. Take care. Bye-bye.